It's my true pleasure to introduce Dr. Scott Rodeo. He's Co-Chief Emeritus of Sports Medicine and Shoulder Service at Hospital for Special Surgery. He's co-director at the same institution for the Tissue Engineering, Regeneration, and Repair program. He's well known to most of us in the field, clinical scientist, specialties in orthopedic surgery and sports medicine, extensive and key contributions to the etiology and treatment of traumatic and degenerative diseases of both knee and shoulder, and doing so in both human and animal models. Particularly germane to today's call is that he's involved in, over the past several years, much research on animal models of stem cell research and tendon repair, but now has advanced to clinical trials for stem cells in rotator cuff injuries. He's also the team physician for the New York Giants since 2015, and I'll note that within that capacity, he's received awards which are complementary to the many other awards that he's received for research and teaching excellence in his career. Could go many more minutes with the introductions, but I'll turn it over to Dr. Rodeo to kick off the call.
Well, thank you for the nice introduction. I'm on the phone. Hopefully everyone can hear me well. So as the title implies, this webinar will address the potential, the perils, and the pitfalls of cell therapy for treatment of knee osteoarthritis. Certainly of all of the various orthobiologic agents available, cell therapy likely holds the most promise for not only treating symptoms, but also for potentially regenerating functional tissue. However, at this time, there really is mainly evidence just to suggest that cell therapy is symptom modifying, with only very limited evidence that cell therapy can be structure modifying, that is, to induce true tissue regeneration. These are some topics we can explore today. There's no doubt that the clinical utilization of cell therapy has outpaced the scientific and clinical support. We've all seen the aggressive marketing that has led to often indiscriminate use. As clinicians, we often have to walk the fine line between embracing new therapies such as this that do have great potential, but also educating our patients as to both what is known, but perhaps more importantly, what is not currently known. As clinicians, we frequently have to answer many questions from our patients, interpreting information that they bring to us from multiple sources, some accurate, some not so. So this webinar will address and discuss the current status of cell therapy for knee OA in particular, focusing on both the tremendous potential, but also the current limitations and the need for further work. We have 4 individuals with extensive expertise in this area. All 4 of these speakers are true key opinion leaders in this field and are well known internationally. We'll start with 2 talks addressing basic issues, followed by 2 clinically oriented talks. So our first talk will be Dr. George Muschler, who is professor of orthopedic surgery and in biomedical engineering and molecular medicine at Cleveland Clinic. Will talk to us on quantitative characterization of cell therapy formulations. And then we'll follow with Dr. Arnold Caplan, who is professor of biology and director of the Skeletal Research Center at Case Western in Cleveland, who has real expertise related to the paracrine mechanism of action of cell therapy formulations. On the clinical side, Dr. Lisa-Fortier from Cornell University College of Veterinary Medicine will speak on the preclinical evidence and share the experience from veterinary medicine. And lastly, Dr. Hicham Drissi, who is professor and vice chair of research in the Department of Orthopedics at Emory University School of Medicine, will speak on a particular study evaluating autologous versus allogeneic stem cell injections to treat knee OA. So with that, we can go ahead and pull up our first speaker, Dr. George Muschler, again, professor of orthopedic surgery, biomedical engineering, and molecular medicine from Cleveland Clinic.
My charge in kicking this off was to talk about measurement and quantification. And so I have no particular conflicts related to this. We all are keyed into the idea that cellular therapy might be useful both in preventing the progression in late disease onto arthroplasty, or perhaps reversing or preventing the progression from early stage disease to later stage disease. And the question is, well, how would that happen? So there are a number of assumptions about possible mechanisms and in terms, for example, of platelets, improving repair, revascularization, having immunomodulatory effects, progenitor cells perhaps regenerating tissue in addition to some secretory properties, and then stem cells giving rise to progenitors and surviving to contribute to that process. We have blood as a potential source of platelets. We have bone marrow and even placenta or fat as a source of stem cells. But in terms of rational development of these things, we have to have a way to measure things that are important. And if I think about things that are important to clinical efficacy, this is going to be a combination here of the concentration of whatever cells we use, their prevalence and how many cells they're competing with, and their biological performance. And then upstream of that, this is contributed to by the source of cells we choose, which will determine the concentration and perhaps the prevalence. Processing methods that we might use that could modify either the concentration or the prevalence of the progenitors that are being used. Processing may also influence the composition and therefore the attributes that we can measure today and the future performance of cells that we provide. And so in this paradigm, I'm going to provide some discussion of measures of concentration, prevalence, and biological performance of these cell sources. So cell source may determine the quality of the materials that we start with and the quantity of materials we start with. Processing may contribute to modifying those components and reducing some elements and favoring others. We have a number of clinical strategies that can and have been used in the clinic, from density separation to selective retention and magnetic separation. I'll focus primarily on density separation since that's most used in the clinic. And this is simply a method to concentrate red cells at the bottom, cell-free or platelet materials at the top, and cellular materials at this interface. It's been around for a long time, but that method, like any method, which you could see in a black box, can take a population of cells and and change it from some concentration of every different cell type there into something else. And in this case, for example, enriching the green cells or the progenitor cells, for example, that might result in an increase in prevalence. It could also deplete cells. And so depending on the therapeutic attribute that you're looking for, if you're trying to get rid of things that you don't want or enrich for things that you do, this strategy could work either way. If we reduce the volume of the cells that we have concentrated or that we selected, we can also change concentration. And so this combination of enrichment and concentration is something that would certainly be desirable in many settings. Purification is yet another thing. The purification means not just, means essentially bringing the prevalence of a particular cell population close to 1. So all these are options, but no matter what cell processing method we use, the efficacy of that method could be measured by one of these various strategies. Now, in the case of PRP, platelet-rich plasma, for example, this is a use essentially of enriching red cells, but using the red cell depleted material. In this case, if we're just enriching red cells over here and keeping the white cells and the platelets, we're providing a leukocyte-rich, platelet-rich plasma. On the other hand, if we concentrate both red cells and white cells over here, we may be providing a leukocyte-poor, platelet-rich plasma. But these are all defined essentially by the concentration of the cells before and after, and then the fold changes in whatever process we're using. Now, these processes vary. The starting materials vary. The ending result varies in terms of concentration. It varies from preparation to preparation, device to device, patient to patient, time to time. And the unfortunate status of most of the studies that we have so far is that they report on the patients, they report on the process being used, but they haven't necessarily reported on the concentration of the cells that were used. And so that's one of the limitations we currently face and why metrics are so important. So in terms of the other components other than platelets, stem and progenitor cells, there's another challenge, one where you find them, which could be bone marrow in this case. Bone marrow comes easily. You can use a needle to get into the iliac crest and aspirate marrow from an iliac crest with a relatively low morbidity procedure, generally requiring some sedation but not anesthesia. If you keep the volume of that aspirate low, about 85% of the cells that you get in the aspirate come from the marrow space and not from the 7 million cells per cc you can expect from blood. But that decreases rapidly as you increase the volume of the aspirate. So keeping aspirates at 2 cc's or less is certainly desirable, and we showed that a number of years ago. If you do this, you can collect 20 cc's and get 40,000 cells. You can collect 100 cc's and get 200,000 progenitors, but that comes with a mixture of a bunch of contaminating cells. So that prevalence is only about 1 in 20,000 cells. In addition to the progenitor cells that might contribute to bone or cartilage formation, which we'll talk more about, bone marrow comes with a mix of other cells. So there's cells that are involving the hematopoietic system, which clearly dominate. There are cells now that are upstream that you don't find in peripheral cells, the progenitor cells for those downstream mature cells. But there are also cells that are adjacent to blood vessels in the marrow, cells on their way or on the bone surface, on their way to or in the stromal architecture of marrow, or on their way to becoming adipocytes. And so this mixture of cells involves a number of different stem cell populations, a number of different progenitor populations. And so it's a complicated mix. So it's a great story, but even though we can get cells that might do this, proving that we have them and that we're doing it is another story. This concept of a stem cell is important. Obviously, many of you remember that stem cells are rare cells that will divide, but they will reproduce themselves, giving rise to one daughter cell that goes on to differentiate, preserving the stem cell for future cycles of remodeling. In this model, a progenitor cell will divide, replace itself, and then give rise through a series of cell divisions to differentiated cells. In this case, we've just modeled this as 6 cell divisions, but what you can see here is that the number of true stem cells versus the number of progenitor cells on their way to becoming something will always be vastly different. So real stem cells are vastly outnumbered, not only by the number of mature cells, but by the number of progenitors on their way in this pathway. So cell source can provide a metric of quality, but because it's heterogeneous and because these are diluted, the demand control over selection and perhaps control. And so understanding that process of the number of progenitors is another attribute of measurement. Much of this, almost all of it, is done in the form of colony forming assays, throwing cells out into a dish, allowing them to attach, and what you see here are colonies that have formed from a single founding cell that attached to a dish. But clearly the cell that gave rise to this colony is different than the cell that gave rise to this. These cells and these cells are also likely to differ. The relationship between the colony population and a tissue is likely related, whether it's cartilage or bone or any other tissue. And perhaps the concentration of these cells may be related to future health, but this is something that still needs to be well characterized. The process of counting them is a variable process. Any one of us could have a different opinion about a given slide, so we've worked hard to take these kind of samples and take images of them to provide a quantitative way to sort through these cells and measure the performance in a way using imaging that allows the same measurement to be taken no matter where one is, and compare not only the number of colonies, but their relative ability, in this case, to form a cartilage-like matrix. And these kind of standards for colony assays have been adopted and accepted by the American Society for Testing of Materials, now ASTM International, and was recently renewed in 2020 after initial approval in 2012. So these are available, and it's a tool to characterize and measure the differences between individuals. Here's one individual with a very low prevalence of progenitors. Here's another individual with a very high prevalence of progenitors, even though 1 million cells were plated in every one of the wells here. So this is a way to help us get at some of these measurements, both the cell population and the progenitor population that's present. In vitro expansion is a very desirable thing. You'll hear Arnie Caplan talk next about the idea of taking those cells, culture expanding them, getting a population of billions of cells from this initial mix of cells. These become much more alike over time, but it comes at the process of forcing them to divide and compete with one another, of course. And that process, even though you start with the same relative materials, may not be the same each time. And we've looked at that question of measuring those biological attributes. You can measure these cells that have been expanded using flow cytometry. So flow cytometry is a way to look at cell surface markers using fluorescent labels. There's a marker profile of the presence of some markers and the absence of others that is associated with these culture expanded mesenchymal stromal cells. And each one of these batches may differ depending on its cell density. And this is an example of the CD90 marker and the CD73 marker. And here in flow cytometry, what you see is these cells are clearly positive, but the positive ones can be, these cells up here can be 1,000 times brighter than the cells down here. So even within this positive population, there's quite a range of performance. We've looked at the value of those markers. These are 8 different patients, 3 different tissues from each patient. We can clearly get these markers that are associated with MSCs to be present. So that allows us to say, well, yes, these are an MSC population. But we also have looked at other markers associated with stemness that you see across here. And it turns out from individual batches, those markers can vary dramatically from one to another. And it's a function of not only the patient, with some patients that are much better than others, but also the function of the sample. So we are currently working on trying to take that very, very promising strategy and refine it still further by learning about what early performance criteria we would like to select and more consistently get to an outcome. But again, this is work in progress. So in summary, there was certainly clinical need. There are a variety of mechanisms and cell sources available. We have a number of metrics that we can apply to measuring the performance attributes and controlling the quality of the starting material, the quality of the processing, and ultimately, hopefully provide evidence that these things make a difference in terms of clinical efficacy and unravel this current question of whether our promise in cell therapy is either still snake oil or a productive, reproducible therapy that we can offer to our patients. So thank you very much. I hope that helps kick off a discussion. I think Arnie Caplan is the next speaker.
I believe that's correct.
And to introduce Dr. Caplan, Dr. Caplan is a renowned professor of biology at Case Western Reserve University and has been a leader in this field of taking the progenitor population that exists in nature and examining it as a therapeutic opportunity by placing cells into culture and expanding them to create a defined homogeneous population that is therapeutic. And his initial interests, of course, were in growing new tissue, and his more recent interest has been in the secretory aspects of these cells and the way in which they can influence the cells around them and our immune system in general. So welcome, Arnie.
Thanks, thanks, George.
Yeah, I'm sorry, this is Scott. I'm back on. This system's not very good. You all set, Dr. Caplan?
I'm ready to go if you'll let me.
Please. Go ahead.
Well, good afternoon, everybody. I'm going to try to talk about these MSCs. Here are my next slide. I need my obligatory disclosures. I started a company called Osiris Therapeutics. Have nothing to do with that company. The university gets royalties and they generously share them with me. So I want to pick up where George left off and talk about the bad actors that we have to continually be careful of. And these are snake oil salesmen who talk about regenerative medicine or stem cell therapies. And I'm going to try to talk around this subject and not get caught up in it. So in 1991, I gave the name mesenchymal stem cells to a group of cells that I could get to differentiate into cartilage, bone, fat, and a variety of mesenchymal tissues. We now know that these cells exist on a petri dish. They don't exist in your body. So the MSCs themselves are all derived from perivascular cells. When these red perivascular cells are on a capillary such as this one that's in heart tissue, and that capillary becomes inflamed or breaks, what happens is that the pericyte is released, the MSC differentiates from that pericyte, and that microenvironment that the pericyte finds itself stimulates the MSC, and from the front of the MSC it makes molecules which inhibit your overaggressive immune system from seeing this injured tissue. So again, this MSC makes this curtain and stops your overaggressive immune system from interrogating the cell. And those molecules that are secreted by that microenvironment have profound immunoregulatory effects. Likewise, these MSCs from the back of the cell secrete a different range of molecules. These molecules set up a regenerative microenvironment which allows this injured tissue to slowly regenerate itself. So we call these trophic factors. These trophic factors now have been studied in great detail in vivo. And here's a partial list of what they can do, and you'll see why this is important. First of all, MSCs make molecules that sit on opioid receptors. So they can, in vivo, actually be involved in the management of pain. They also inhibit scar formation and stimulate the removal of scar. This has huge opportunities for regenerative microenvironment. And likewise, the MSC secretes mitogens, which actually stimulate tissue-specific and tissue-intrinsic progenitors to divide and to differentiate along a very narrow pathway so you can get regeneration of that injured tissue. They bring in new blood vessels, and also if these new blood vessels that are brought in are very fragile, if the MSC is going to engraft, which is very rare, it will engraft again as a pericyte and stabilize those new blood vessels. Completely unanticipated from our early work is that MSCs make antibiotic molecules, peptides, that kill bacteria on contact. These molecules, these peptides, also have antiviral capabilities, and that's going to have a profound effect when MSCs actually are used in COVID patients, as I'll discuss at the end. MSCs can control and contribute to wound closure and wound healing, and most importantly, they change this microenvironment of macrophage and monocytes that are in this injury site, and they generate, cause the generation of T regulatory cells, which can stay around for years and years and actually continue to produce therapeutic molecules. So MSCs, again, are not stem cells. They're derived from perivascular cells, not from the stroma, not from the connective tissue. And 10 years ago, I suggested changing their name. I want to keep the MSC nomenclature, so I now call them medicinal signaling cells. And again, they have this range of capabilities, anti-inflammatory, anti-immune system, and antiviral, again, has huge effects on treatment of COVID patients. If you put mesenchymal stem cells into the search engine of the website, clinicaltrials.gov, today you'll get over 1,100 clinical trials that are listed there. Here's a world map. You can see where they're located. This is a map of the United States, 228. I'm hugely politically active, and now that That's clearly on all of our minds. And I don't particularly like red states, but on this map, I love red states because these are the states with the highest number of MSC-specific clinical trials: California, Texas, Florida, and there's Minnesota way at the top. How could a cold state like Minnesota have so many clinical trials? Mayo Clinic has been working with MSCs for over 10 years and has a variety of clinical trials. Here are all the clinical symptoms that I've copy-pasted. I've put them in higher font for all of you older participants whose eyes can't read the smaller type. And I'm going to focus on osteoarthritis. But again, MSCs are not stem cells. MSCs are drugstores for sites of injury, and they actually are the sentinels that help regulate the intrinsic regenerative capacities of cells. 5-year-old breaks a leg, 3 weeks later, fine. I break a leg, 3 months. Clearly, older individuals have fewer MSCs and don't manage this well, so I need a booster shot if I break my leg. And again, the orthopedic surgeons, since the 2,000 years ago, knew that marrow contained these kinds of cells, not only progenitors for osteoblasts, as George Muschler just pointed out, but also for these cells that are derived from perivascular locations that have medicinal capabilities. So I would shoot up to get my booster shot. Those cells dock at sites of injury or broken blood vessels or inflamed blood vessels. They provide an immunoregulatory component, a regenerative component, and they are the managers of the body's innate capacity to regenerate. So this is a very important study, and I put it here to be very specific about the management capabilities of MSCs. MSCs do not engraft, as this study clearly shows. MSCs, whether they're autologous or allogeneic, have huge influential effects not only on the cells at the site of injury, but on monocytes and phagocytic cells in the neighborhood, including macrophage. Eventually, these cells are very rapidly cleared from that site, but still months and months and months later, we can see the therapeutic effects of these cells. So again, MSCs do not engraft. MSCs do not form cartilage tissues at sites of damage in the knee. MSCs make drugs. And there's many, many studies, including clinical trials. I'm only going to focus on this one because of time, focus on this one study outlined in purple at the bottom, in which very late stage OA patients are given 1 million, 10 million, or 50 million bone marrow derived MSCs, expanded cells, into the knee joint, and patient reported outcomes are scored at various time intervals, particularly I'm going to focus on 12 months, but KOOS scores, WOMAC scores, and actually magnetic resonance imaging is used for worm scores to look at the status of the cartilage within that joint. And what you see from the introduction of these bone marrow MSCs is there's a significant overall improvement in KOOS scores, pain goes down, in WOMAC scores, stiffness and other scores, and also you see a stabilization, a decrease of the degenerate events of the cartilage as indicated by MRI, quantitative MRI imaging. So these analytical tools provide important insights into bone marrow MSC dosing. The highest doses seem to be the most effective, although you see whether you get 1 shot or 2 shots of MSCs actually has an effect on the sequelae of OA, but also it affects the microenvironment within the synovial lining, and also grossly affects the synovial inflammation and cartilage degradation. So again, this is from this paper, and there are a group of cytokines and growth factors that are listed here, PGE2, PDL1, IDO, HGF, TGF-beta, and you see by this red line that all of these guys are on, they're on full, and in principal component analysis, these are actually predictive of very positive scores on patient-reported outcome measures. So again, it turns out that the highest dose, 50 million cells, gave the best results. So again, here's a different study. In this case, just so to emphasize what George Muschler said, you can get MSCs from any tissue of your body as long as they have vasculature, because these are perivascular cells in their origin. And the tissue which has a huge vascular supply is fat. And so you get 300 to 500-fold more MSCs per cc of fat than you can for bone marrow. Here's a study, a randomized controlled trial, reported to be the first of its kind, from fat-derived MSCs. And in this case, what you see at the 12-month outcome, and I'll show you the sequela of scoring, is that there's a significant pain and functional improvement of these patients. Pain scores go down, the WOMAC scores are improved, the KOOS scores are improved, and what you see is the favorable outcomes, as again reported by patients in this investigator-initiated clinical trial. Here's actually the actual scores that I copy-pasted from the paper, and what I want you to notice is that the blue lines are 2 injections, and the green lines are 1 injection. Both produce significant positive effects, but eventually the long-term highest effects are from 2 injections. And again, the dose is important. So in conclusion, I want to say MSCs can be very valuable for the treatment of OA, and there are a number of clinical trials now in play looking at OA, RA, and lupus, and a variety of inflammatory situations. The important aspect is that MSCs don't arise from stroma. MSCs arise from perivascular cells. When culture expanded MSCs are put back into a patient, they dock at sites of injury and or inflammation. They survey and sense that site and respond by the microenvironment that they sense. They can modulate the immune system because they have this huge immunoevasive, immunomodulatory capabilities. Allogeneic MSCs can be used. It's important to understand that MSCs can make pro-inflammatory or anti-inflammatory molecules. If you have an infected joint with lots of bacteria, you want a pro-inflammatory microenvironment that brings in macrophage and monocytes to eat up those bacteria and to neutralize them. If you have a huge inflamed joint, you want anti-inflammatory molecules. Again, MSCs manage pain by secreting molecules that sit on opioid receptors. They bring in new blood vessels into the synovium. They provide antibacterial and antiviral activities. There's now trials using culture expanded MSCs to treat very severe COVID patients, and in non-controlled reports with very few patients, probably on the order of 150 patients, the results are quite spectacular. Immunomodulatory and regenerative, those are the 2 capabilities. Again, they make mitogens for tissue intrinsic progenitors, which are sometimes called stem cells. They inhibit scar formation, and there's a couple of papers now that clearly show that MSCs are eaten or consumed by a special class of monocytes or macrophage. Those cells, in eating the MSCs, actually change their cell surface characteristics. And when they bump into a T cell, they convert the T cell to a regulatory T cell at that site. The regulatory T cells can cross the blood-brain barrier. They can stay in a particular tissue for years and years. My bet is that they are the long-term therapeutic mediators, not the MSCs. So although the MSCs make a lot of important molecules and stimulate a cascade of events, they don't stick around a long time. And if you're seeing 12-month outcomes that are enormously positive, there's other cells that are at that site that are producing these therapeutically important molecules. MSCs are not stem cells. I beg you, stop using this term stem cells. All the studies in my lab are supported by NIH, and of course, I'm indebted to all of my colleagues at Case Western Reserve University and the Skeletal Research Center for adding value to the research I do. Thanks.
All right. Thank you, Dr. Caplan. I think the system finally let me on after an hour of trying here. Can you hear me, Rodeo?
Yeah, you look good, Scott.
You found me. I'm sorry. It took me with some technical issues here. Thank you. That's a wonderful summary. So we have those two basic background talks. Now we have two clinical talks. We'll start with Dr. Lisa-Fortier, a good friend and colleague, and really a widely recognized expert in this area. Lisa is a veterinarian and PhD, full professor at the College of Veterinary Medicine at Cornell University. We'll talk to us from the veterinary perspective and kind of cover preclinical evidence, the experience in veterinary medicine. Lisa.
I think you need to stop sharing so I can share it. There we go.
I don't even know what I did. There we go.
Oh, I think we're good.
Good.
Is that showing the...
Got it.
Got it? Great. But it's not showing in... There we go. Thank you, Scott and Arthritis Foundation for having me today. As Scott said, I'm proudly a veterinarian, and in fact, I'm an equine surgeon, and these are my disclosures. As a veterinarian and as a preclinical animal model person, and we've done a lot of this work with Scott as well, horses and dogs are actually both patients and models for me to study musculoskeletal regeneration. I focus on the horse, but I'm also the director of a clinical trials center here at Cornell, where we do a tremendous amount of dogs. I'm sure most of you who've had dogs know there's elbow arthritis, shoulder arthritis, hip arthritis, degenerative joint disease in their back. Obviously the original Panuki, which is the transection of the anterior cruciate ligament in dogs, was really probably the first of the robust large animal models for studying arthritis. So to me, these animals are both patients and they're animal models. So when I can improve their health and human health, it's a home run for both of us. In these two scenarios, the types of cell therapies that we use for osteoarthritis include adipose tissue, either cultured at culture expanded, stromal vascular fraction, or micronized adipose tissue. We also use a lot of bone marrow derived, either cultured or bone marrow concentrate. The most common indication in horses would be either metacarpal phalangeal joint, as I'm injecting here, also known as the ankle, or the stifle, which is known as, which is also the term for the horse knee, which is just over my shoulder back here. In dogs, it's probably hip arthritis is the most common as a sign of hip dysplasia, but elbow and shoulder and lots of other things as well. We do all of our injections ultrasound guided. Here's a dog hip, here's the acetabulum, the femoral head, sorry, and the acetabulum with the needle. You can just bear, I didn't want to play the video, but the needle coming in right here. So we're doing culture expanded bone marrow derived mesenchymal stem cells under FDA guidance here at Cornell. I agree we need to rethink the mechanism of action of MSCs. We did this TALR impact model. So what we could do in Larry Benassar's words is deconvolve the system so we don't have the blood and all the other instability of a cruciate ligament or meniscal injury. So we take this impactor, which was originally designed by Rocky Tuan's group, and we outfit it with a LVDT so we can measure not only how hard we hit cartilage, but how fast we hit it. And then we'll impact the medial trochlear ridge of the talus 3 times, so we can measure exactly how much impact the horse's medial talus actually got. So there's 1, 2, 3 impacts. This is the joint on a horse upside down, so the hock or the talus. What's really cool about this system is we can use the same impactor in the laboratory to do some very, very simple and elegant calcium signaling and lots of other things that were done in conjunction with Benassar, and Itai Cohn is a physicist at Cornell. And then we can take this to the in vivo situation as well. And both Peter Alexander, who's at Pittsburgh still, and Rocky Tuan have used this impactor as well. And so we can take normal cartilage or give it a slight bang or a harder bang or harder and harder. And really we can model then mild, moderate, or quite severe osteoarthritis. And so we use this model for the first time after we validated the model to test this specific type of MSC, this alpha 10 beta 1 MSC, in compliance with the FDA. It was a GLP study for preclinical practice in Europe. And we use that TALAR impact model. And you can say, well, why did we select these cells? The idea from the company, this was funded by Xintella Incorporated out of Lund, Sweden. Their idea was that these cells would be selected because the hope would be that the cells then could stick to expose collagen on the articular surface, and that maybe they would stick around a little bit longer. Whatever you want to think about that, that's why they were selected like that. They did show, of course, once you select some of these cells, that they have an increased chondrogenic potential. They showed immunomodulation, that they are MHC class 2 negative, and they do show that they adhered to damaged bone and cartilage. So the idea is to take this super heterogeneous population that Georgia talked about earlier and get it down to a little more selected population as well. So when we put these horses down, the first thing that we noticed, these are on the left are the trochlear ridge of the talus. So far left would be, this would be the medial trochlear ridge of the talus. And then after we open it up, we wipe it off and paint it with India ink, which it's just particulated carbon and should stick to fibrillated articular cartilage. Very simple way of assessing articular damage, both where you impacted it, which is 1, 2, 3, and then you can see some damage throughout the talus here, and that the lateral trochlear ridge of the talus is quite happy. And we look for off-target effects in lots of places, including the distal tibial surface. But maybe what you can see when you first look at the treatment side over here on the right side is how shiny this surface is. And that was just something we didn't a priori plan to look at, but once we started opening up these joints, it became very clear that there's something different about these sides. And we couldn't actually find where the impact was. Even after you stained it with India ink, it was very, very difficult to find where the impacts were on these horses. Again, not a priori, but setting up to think, well, what could this be? Lubricin, or was the cartilage actually intact? Was it HA? What is really helping this cartilage stay shiny, or for lack of a better word? Of course, we did standard SAPHO and H&E histology and just show a couple of them here. But interestingly, at a year after impact, and these MSCs were injected 4 days after surgery, you can see that there's significantly less cartilage damage and subchondral bone damage in the MSC treated side than in the control side, where there's extensive loss of proteoglycan, and then we had a non-impact control. And this was significantly different in the MSC treated side compared to impact with saline vehicle control. Heidi Riesink is also a veterinarian here, and she's one of the leading experts now in lubricin and articular cartilage. And so she has an equine lubricin antibody that we were using, and then we used wrote an ImageJ protocol to look and see what was going on. And here's normal lubricin in normal control cartilage. In the impact, it significantly increased both in intensity and in depth throughout the articular cartilage compared to control. But that's also increased even further in the impact plus treated MSC treated side, where you can see quite strong intensity of lubricin treated in not only intensity, but in depth as well. So maybe that's having some protective effect of the articular surface. As Arnie just talked about, PGE2 is very, very commonly looked at, and we looked at lots of the same synovial fluid markers, but what I really wanted to highlight here were some of the things that I think we were able to understand in the animal model as far as as far as disease modifying rather than just pain control. But what did we really find that was disease modifying, and how might we rethink how stem cells are working? Stem cells, sorry, Arnie, MSCs. One of the very interesting things that we found, so when we looked at the radiographs of these horses, we radiographed them every 2 weeks throughout their entire 6-month duration. And then we consensus scored them with 3 boarded equine surgeons, and we found that there's significantly less sclerosis, subchondral bone sclerosis in the medial trochlear ridge of the talus at 6 months compared to either pre-op or at 6 weeks. We wrote another IMAGE-J protocol looking at quantitative analysis of either subchondral bone sclerosis or, interestingly, thickening of the subchondral bone plate. The horses naturally have a bit of a thicker subchondral bone plate and a little bit more dense than in humans, but we found that there was significantly less bone sclerosis in the MSC treated side and less thickening of that subchondral bone plate. So sclerosis is the loss of these medullary elements, but then the increase in the depth of the subchondral bone plate is from the calcified cartilage down. So both of those were less. I don't think they were actually reversed. I think that the impact side kept getting worse and worse, and the MSC treated side just never really got as bad. So maybe if you have this harder or subchondral bone, then that leads to more cartilage damage. Maybe the lubricant helps as well. So a couple different ways to look at, rather than just MRI of the articular cartilage, but to pay some more attention to the subchondral bone for long-term success. The other interesting thing that we found when we were looking at the synovial membrane histology, and this is a little bit what Arnie said about, we always think more cells is bad. It looks like a autoimmune reaction, immune reaction. And we saw this increase in mononuclear cells in the MSC treated side compared to the impact treated side. And it was significantly increased really at the 6 months post-op. So many, many more mononuclear cells, not any more fibrosis. The collagen wasn't any more increased, but the mononuclear cells, not neutrophils, but what looked like macrophages and or lymphocytes primarily, were significantly increased. So we didn't take synovial membrane a priori. So we went back, and this is something Scott Rodeo and I worked on when I was at his place on my sabbatic. And we custom designed an equine nanostring panel. And when you compared the impact with the MSC treated side compared to control, long term at 6 months, we find that the MSC treated side had decreased TIMP2, NF-kappa B, and CCL2, which is a chemokine for a lot of our macrophages and monocytes. So I would concur that really where we need to be looking for the action of our MSCs is really in the synovial membrane and the fluid, and the cartilage is probably an innocent bystander. But those are just some novel things that I think we found in this equine study that can help us rethink our mechanism of action of MSCs. So the future directions, we do know that allogeneic cells are antigenic. We know that if you put 2 injections into an animal and harvest that serum is cytotoxic against cartilage and other immune cells. What does that mean? Does that mean they're less efficacious? Does that mean that we can microencapsulate them and hide that? Because even if they're MHC class 2 negative to begin with, most of the cells become MHC class 2 positive. So how can we hide this antigenic capacity? And if you're going to start to treat somebody in their 40s or 50s for arthritis, they might need an injection every year or every 2 years. So I think we need to really start considering the antigenicity. They're for sure still immunomodulatory, but they do spark an antigenic response. And George and I have already had offline discussions about how do you measure the quality of some of these, especially in a bedside manner. It's pretty relatively easy for us to take them to the laboratory and do flow cytometry and all these things, but how can physicians, clinicians really determine what they have for MSCs? And it's really bothered me for a long time that people say, well, nucleated cell count or colony forming unit are a surrogate marker for MSCs. And we've just done a 28-horse study looking at bone marrow concentrate and very clearly show that neither nucleated cell count or colony forming units, we count colony forming units in 2 different ways. They're not even close to a surrogate marker for MSCs. So I don't know what the marker is. Maybe George can find that, but I think we really, really need to be careful when we're looking at clinical outcomes and comparing nucleated cell count and trying to find some correlation between that and outcome. And those are my acknowledgements. Thanks again for having me, Scott.
That's wonderful. Thank you. Thank you, Lisa. That's lots of food for thought there. We'll have some good questions for discussion at the end here. We'll move to our fourth and final talk, and then we can move into our discussion. We have Dr. Hicham Drissi, who is professor and vice chair of research in the Department of Orthopedics. He's professor of cell biology at Emory, University School of Medicine. He'll talk to us on a particular study designed, look at the promises of autologous versus allogeneic cell injections for treatment of knee OA. Hicham, please.
Oh, thank you so much for the opportunity to present. Dr. Caplan, you can appreciate how fast of a learner I can be. We're now going to call them stem cells or even progenitor cells. So from now on, they're going to be medicinal cells. So as everybody already alluded to, osteoarthritis is a whole joint problem. We very often focus on cartilage, but synovium and subchondral bone also undergo tremendous changes, and therefore finding ways to be able to target the OA as a multifunctional tissue pathology is very important. Evidently, you get multiple ways of dealing with this problem, and starting with conservative treatments, going into pharmacologic pain relief injections, arthroscopic treatments, and ultimately arthroplasty. And so in 2011, it was estimated that about 18 million Americans were living with symptomatic knee OA. 4.1 million of these exhibited difficulty with ambulation and are good candidates for knee arthroplasty or HTO. Yet only 500,000 knee arthroplasties and HTO are performed annually in the US, which means that about 3.6 million Americans linger in a treatment gap, whether they don't want to have the surgery because they're scared or for other reasons. And we need to find ways to deal with these patients. And so with the discovery of the medicinal capabilities of these progenitor cells, came cell-based therapy for knee OA. And cell-based therapies have been widely used for multiple applications. And while this is a lot of money that is being spent by these patients for multiple applications, not just OA, there is unfortunately still not enough data to support or to be able to justify the use of these as procedures in various clinics. And so there are at least three reasons for us to want to do more RCTs with stem cell injections. Number one being for the patient's sake. Also, payers will demand data. We also want to help people with proven treatments rather than administer treatments that have no validation behind, and also perhaps prove that these MSCs work. And find the best cell source eventually, learn more about how to predict success are some of the questions that we should be thinking about. So if you look at the registered clinical trials for just knee OA using MSC injections, and this is not as wide as the one that Dr. Caplan showed us earlier, you can see that there's about 146 trials that have been registered with clinicaltrial.gov with MSCs used for OA, 48 of which are completed, 38 are still recruiting. And then you have some where you can enroll by invitation only or not yet recruiting, 7 withdrawn, 19 are of unknown status, 2 are terminated, and 1 that was suspended. And so out of these 48, there are about, I would say 21 or so manuscripts that came from with data from these RCTs that are registered in clinicaltrial.gov between the period of 2017-2019, with 10 in 2018 and 8 in 2019. And Dr. Caplan already pointed out some of the most intriguing or interesting ones. You can see that these are going to be either using autologous cell injection, and will have pain and functional outcomes as the main outcome measures, as well as having different times or follow-up times in their utilization. And so one of the striking things that you can see here is that these are typically of a study size that's that can be as low as the teens into perhaps 40 something or 50. Of course, there is this concept of whether we need to do a single or repeated injection, and it's obvious that repeated injections seem to show some tremendous promise in the future. Also, what we have found is a series of publications in which allogeneic cells have been used, including umbilical cord-derived MSCs, some placental MSCs, as well as other allogeneic cells. So basically what we've learned from this is that the first single-blinded placebo-controlled trial of BMAC injection by an investigator in Mayo Clinic showed that pain relief was observed at 3 and 6 months post-intervention in both MSCs and saline placebo. So the saline placebo was actually as effective as the MSC for a study in which bilateral OA was used, and the placebo was on one knee, and the MSCs or BMACs were on the other knee. Injections from both autologous and allogeneic sources appears to be safe and reliable, and no significant adverse effects have been reported. So this is a very good first step towards designing the next generation of clinical trials. These MSC injections demonstrated clinically significant pain and functional improvements as early as 6 months, but definitely within 12-month follow-up. So it's based on these that we still have some questions that we would like to ask. And these pertain to the fact that there is a gap in knowledge in terms of comparison of cell sources within the same trial, as well as validation of the criteria for the injection products, cell characteristics or preparation techniques, etc., etc. It would also be helpful in an ideal world to be able to predict the efficacy of the cells that we are injecting. And so we're thinking about these questions as they were very important even in the previous presentations. And so what we've decided to do was to seek funding from the Marcus Foundation to be able to do a multi-center clinical trial that we are naming multi-center trial of stem cell therapy for osteoarthritis, or MILES study. This is going to address the following objectives. And so is there a superior, since we can't say that an optimal cell source may exist, but is there a superior source or a hierarchy in the efficacy of progenitor cells or medicinal cells for knee OA injections? And how does it compare to a traditional gold standard treatment such as corticosteroid injections? The other question we want to ask is, can we correlate these clinical outcomes that we will receive to cell characteristics? Because very often we inject these cells, while we can't go and retrieve them from humans like we can do in preclinical studies, knowing at least what goes in would be of tremendous importance in terms of what these cells can be. And so this trial is between Emory University, Stanford Health, Duke University and Andrews Institute in Florida. And the cell characterization is being done by the Marcus Center for Therapeutic Cell Characterization and Manufacturing in Georgia Tech. So these are our partners. So overall, the protocol is an exploratory with intent to treat trial, unilateral NEOA, and it's considered a phase 3. We have 3 arms and a total of 480 patients across 5 study centers. It will be about a 2-year trial with 1-year follow-up. We have 9 inclusion and 25 exclusion criteria, and I'm just going to discuss the inclusion criteria of some of them very briefly so that you have a good idea of what we're trying to achieve here. So we're recruiting male and female patients, age 40 to 70. Of course, they need to have radiographic evidence of OA and have a diagnosis of OA in the targeted knee. Of course, in order for us to be able to see improvement in pain, there has to be a minimum VAS scale of 3.